Good morning. In this video, we're going to talk about diseases of the pancreas. First, we're going to talk about acute pancreatitis. Acute pancreatitis is an inflammatory disorder of the pancreas that is characterized by edema and when severe necrosis. Etiologic factors include alcohol, which is the most common, biliary tract disease, hyperlipidemia, could be hereditary, then hypercalcemia, trauma, ischemia, pancreatic duct obstruction, infections, venom, drugs, and could be also idiopathic. It occurs in various degrees of severity, the determinants of which are multifactorial. And for the diagnosis, it could be diagnosed by typical abdominal pain, then 3 times or greater elevation in serum lipase and or amylase, and confirmatory findings on CT scans. So as shown here, this is a CT scan of patient with acute pancreatitis. You will see here this one labeled G, this is the gallbladder, and the one with P is the pancreas. And the one pointed by the arrows are the necrotic pancreas caused by the acute pancreatitis. For the management, severe pancreatitis carries a mortality of 80%, and interventions in the first 24 hours can help minimize the morbidity and mortality. So there are scoring systems in acute pancreatitis. We have the Ranson's criteria, the Apache scoring. Just read on it on your smarts. And then other management includes IV fluids, then relief of pain by giving analgesics, antibiotics, and nutritional support. What is the role of surgery in acute pancreatitis? So the role of surgery is cholecystectomy should be performed as soon as the patient has recovered and the acute inflammatory process has subsided. And the second role is in pancreatitis is to debride pancreatic necrosis, or what we call the necrosectomy procedure. Now we go to chronic pancreatitis. Chronic pancreatitis is an incurable chronic inflammatory condition that is multifactorial in its etiology, highly variable in its presentation, and a challenge to treat successfully. Etiology includes genetic mutations, alcohol exposure, duct obstruction due to trauma, gallstones and tumors, and also metabolic diseases. The diagnosis of chronic pancreatitis depends on the clinical presentation, a limited number of indirect measurements that correlate with pancreatic function, and selected imaging studies. It can be diagnosed by using ERCP. This is the most sensitive radiologic test for chronic pancreatitis. Also, CT scan. CT scan is sensitive for the diagnosis of chronic pancreatitis when calcification, duct dilatation, or cystic disease is present. However, it is not accurate in the absence of these findings. We also have endoscopic ultrasound. This is highly reliable in ruling out pancreatic carcinoma when CT scan findings are normal or equivocal. For the management, the choice of operation and timing of surgery are based on each patient's pancreatic anatomy. So the following procedures are done in patients with chronic pancreatitis depending on the case of the patient. You can do sphincteroplasty, can do drainage procedures, distal pancreatectomy, or total pancreatectomy. Now we go to another complication of acute pancreatitis, which is the pancreatic pseudocyst. Pancreatic pseudocysts are a collection of fluid around the pancreas. The fluid in the cyst is usually pancreatic juice that has leaked out of a damaged pancreatic duct. As mentioned, it arises from acute pancreatitis or chronic pancreatitis. It may develop soon after an attack of acute pancreatitis, and it can present many weeks or months after recovery. Clinical presentations includes abdominal pain, feeling of bloating or poor digestion of food, deep ache in the abdomen, and complications related to the pseudocyst such as infection of the pseudocyst with pancreatic abscess, bleeding onto the pseudocyst, or blockage of parts of the intestine by the pseudocyst. Laboratory exam would reveal a persistently elevated serum amylase, and on radiologic finding, it could be diagnosed using ultrasound, which is a 75 to 90% sensitivity, but CT scan is the most accurate which has a sensitivity of 90 to 100%. In this picture, this demonstrates a pseudocyst, the one pointed by the arrow, in the tail of the pancreas, surrounded by a thick enhancing wall. The lesion appears heterogeneous with central areas of higher attenuation, which is suggestive of fresh hemorrhage. So note the infiltration in the arrowhead of the peripancreatic fat. For the management, all cysts do not require treatment. In a significant number of patients, the cyst will just resolve, so more than 50% of patients. In a patient with a small, like say less than 6 centimeter cyst with no symptoms, careful observation of the cyst with periodic CT scan is indicated. But if a pseudocyst is persistent over many months or causing symptoms, then treatment is required. So the interventions that could be done in pancreatic pseudocyst includes percutaneous drainage, endoscopic drainage, and surgical drainage. The indications for drainage includes presence of symptoms of more than 6 weeks, enlargement of pseudocyst at least more than 6 centimeter, when there's already complications such as bleeding or abscess, and if there is suspicion of malignancy. The surgical options includes excision of the pseudocyst. If the pseudocyst is located at the tail of the pancreas and along with proximal strictures, distal pancreatectomy and splenectomy should be done. While if the pancreatic pseudocyst is located in the head of the pancreas with strictures of pancreatic or bile ducts, then pancreatic duodenectomy should be done. And another option would be external drainage. Now we move on to pancreatic tumors. So pancreatic tumors are divided into two: the neoplasms of the endocrine pancreas and the neoplasm of the exocrine pancreas. The neoplasm of endocrine pancreas includes insulinoma, which is the most common, non-insulinoma, hyperinsulinemia, hypoglycemia syndrome, gastrinoma, vasoactive intestinal peptide secreting tumor, glucagonoma, somatostatinoma, non-functioning pancreatic endocrine tumors. You can read the details of these in your slides. For the neoplasm of the exocrine pancreas, we have pancreatic cancer. Pancreatic cancer is the 10th most common cancer and the fourth leading cause of cancer death. 80% of cases are adenocarcinomas from exocrine pancreas, and the median diagnosis is 70 years old. Risk factors include smoking, low vegetables and fruits, high red meat, chronic pancreatitis, diabetes, obesity, and can also be hereditary or genetics. The presentation is nonspecific. For tumors of the body and tail, that is 25%, would have patients would have pain and weight loss. And for tumors of the head, that is 75% of patients would have jaundice, steatorrhea, weight loss, and pain. For the laboratory findings, you would see increase in liver function test and elevated CA199. This is a tumor marker for pancreatic cancer. Okay, this picture shows a pancreatic tumor at the head of the pancreas. This head of the pancreas tumor is blocking the pancreatic duct and the common bile duct. So the bile cannot pass through the pancreatic duct and common bile duct and to the duodenum. That's why patients will have jaundice. For tumors in the body or tail, they are more likely to present with pain or weight loss because the common bile duct and the pancreatic duct are not blocked. Radiologic imaging of pancreatic cancer will show on ultrasound there would be bile duct distension and a mass. So as you can see here, the one printed in yellow, that's the mass in the pancreatic head, and the dilated bile duct and the pancreatic duct. Triple phase CT scan has a 90% accurate at finding the lesions. So the one encircled in green is the mass in the head of the pancreas. Endoscopic ultrasound is helpful in finding lesions which is not seen on CT scan. It will also help determine resectability and has a excellent way to get biopsy So this is the endoscopic ultrasound, and endoscope is inserted through the per RM, and then it goes to the duodenum. This is the ultrasound tip, and it can get the uh, detailed image of this area. So you have the endoscopic ultrasound. Another way is by ERCP. ERCP is therapeutic as well as also diagnostic. So this is ERCP. Also a scope is inserted to the duodenum up to the ampulla, and then a catheter is placed going to the CVD and the pancreatic duct. So what you look for in an ERCP is when you inject the dye into the catheter, you look for a compression. So when there's compression, meaning there is blockage of the pancreatic duct. This is the clinical staging for pancreatic cancer. We are using the TNM classification system, but we will not go into detail uh, into this. You can read it on your SWOT. So this one here shows the prognosis for each stage. For stage 1, it is a 20% 5-year overall survival rate and the 70% relapse. For stage 2, has a 10% 5-year overall survival, and stage 3, 2.5% 5-year overall survival. And for metastasis, patients in stage 4 who has a liver, lung, and peritoneal cavity, it has a 1.6% 5-year overall survival rate. For the treatment, surgery is the only curative therapy for pancreatic cancer. About 20 to 30% of the patients are operable, that is in stage 1 or stage 2 pancreatic cancer, and 70 to 80% are already inoperable, that is stage 3 or 4 pancreatic cancer. The surgical procedure that can be done for patients with pancreatic cancers are if the pancreatic tumor is located at the head of the pancreas, then the surgeon can do a Whipple procedure, or this is a removal of the distal stomach, shown in the picture, removal of duodenum and proximal jejunum, the head of the pancreas, and gallbladder and common bile duct. And for tumors of the body and tail, distal pancreatectomy may be done, that is, removal of the body and tail of the pancreas as well as the spleen. Okay, to summarize the treatment of pancreatic cancer, resection is the only chance for a cure, and resectable patients should undergo surgery without delay, followed by adjuvant therapy. Borderline resectable patients may benefit from neoadjuvant therapy and then surgery, and for unresectable patients, they may benefit from chemotherapy or chemoradiation. For metastatic disease, they may also benefit from chemotherapy or other palliative treatments. So that would be all for diseases of the pancreas. Thank you for listening and stay safe always.